Inside the Boards is supported in part by Firecracker. Firecracker has been helping medical students succeed in medical school from day one by integrating all the content taught in one convenient website and phone app. I personally loved using Firecracker because whenever I got something wrong, I could easily review that topic. One of my favorite features about Firecracker is the daily vignette. Basically a lengthy board-style question to test your knowledge. You'll also love the dedicated test prep mode. Their 1,200 board-style questions will definitely maximize your learning and score. Whether you're studying for STEP, COMLEX, or a shelf exam, try learning medicine the Firecracker way.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
Welcome back, Boards Insiders. Today we have a short holiday episode brought to you in part by Firecracker. I guess it's a holiday episode because we haven't managed to record until, well, the holidays. I hope that that'll be changing pretty soon in the upcoming year, so look forward to more podcasts from us. Until then, here's Patrick and I discussing some nephrology questions from Firecracker. Happy studying and happy holidays.
Well, Stuart, it's been a long time we haven't talked. I've had a few changes. You're now in second year, almost halfway through, and now's the time to just wish everybody Merry Christmas, Happy Holidays, and give a little update on the ITB podcast. So that's the goal for today.
Yeah, have a little holiday gift for everybody who subscribes to us, right?
Right. And speaking of a holiday gift, Firecracker reached out to us and wanted to let our audience know about a holiday sale that they have going on until Christmas Day. You can take advantage of that deal, firecracker.me/purchase/ITB. That's firecracker.me/purchase/ITB. And because of this kind of episode being sponsored by them, we're going to end up going through some nephrology questions from the Firecracker database. But before that, let's check in with Stuart and see where he's been over the past half a year. So how have things been going?
Things have been going really well. Okay, so I think one of the big changes that I've made really coming into second year is a big focus on doing questions and, not just sitting there memorizing material. And I couldn't be happier with that approach to learning, just by testing yourself and doing question books, just looking up questions wherever you really can find them, and getting started on these kind of question banks to understand what people are really, focused on testing and what they find important before you get to your actual test. So that's worked really well for me. And, I've been able to do really well with that. And it's made me kind of happy to come back into medical school really strong. And I think the approach that we've talked about here on the podcast has really helped me figure out what I need to be doing when I'm studying, rather than just sitting there and memorize material over and over again, but you're not really applying anything.
Yes.
So the questions really help me apply some of that material and actually, I guess, ingrain it a little bit to what they're wanting us to know.
Yeah, and I think we talked about offline before that. The goal of medical school is to learn medicine, and you can do that in a number of ways. But if you are going to specifically be faced with a challenge like the USMLE Step 1 or one of the tests at your school over a particular subject, you've got to do the work that specifically trains that part of your, learning system, learning musculature,
Exactly.
If you will, you can be really, really fit, as a swimmer cardiovascularly, or you can achieve great health by, being a cyclist, or running a marathon, but you're not going to be a marathoner and post a good time unless you actually do running as part of your exercise and training regimen. And that's, I think, how questions go. And my experience, I think, was similar, where I did a lot of textbook-based study, and you still have to do some of that and the notes, but it was really when I started, doing things that applied what I was learning, quiz-based learning through multiple choice questions, that I, felt like I had a better handle on the material, and also more confidence when it came to testing. So good for you for, wading into those waters.
Yeah. And I'll comment on that. Like, I didn't throw away my notes completely. And as I don't want the listeners to get the appearance that I just studied questions. I did look at material, but when it came down to actually preparing for tests and things, it was all about just doing the questions, figuring out what was important in the questions and what was being taught there. And like you were saying, just about practicing for a marathon, you have to run to practice for the marathon. Well, for a test in medical school or the board exam, you have to practice for it. And doing the questions is just the best way to do that. You could rewatch lectures or read notes, but you're not really applying it the way you need to be. And I kind of like that. It's kind of a lot like if you read any book about performance or listen to any book, like an audio book or something, you'll hear about Anders Ericsson and Angela Duckworth research, and it's all about, working hard and doing the task that you need to be doing deliberately in order to get better at it, right?
Yeah, absolutely.
So if you're not testing where you want to be, you have to be practicing at testing where you want to be. And part of that is just doing a bunch of questions and getting them wrong and figuring out why you got them wrong, right?
Absolutely. Yeah, and that's so you can do that with really any QBank. And I think you've used quite a few, but you do have some experience using Firecracker, right?
Yeah, so I used Firecracker kind of leading up to taking my break from medical school, and I just recently started back using it again, just because I did really like the way the platform is set up. And they send you a question every day, and that it's always kind of fun to do that and see how you do when they're just testing you on something that may or may not be a part of your coursework at the moment, right?
Yeah, totally. So I guess since they are sponsoring this episode, what is it about the platform that you like as a user?
Yeah, obviously the clinical vignette they send you every day is fun. It used to be you just get one. Now you can do as many as you want, which I think is a great new feature. But the real important feature of Firecracker is the data. So it basically is like Anki or Osmosis or any of these flashcard apps where you look and you say, oh, I didn't understand this question at all, and it'll bring it back to you faster. So it will do this sort of spaced repetition with you.
Yeah.
But what it does is it gives you a good profile of, where you are with each subject. You can read into subjects and learn more if you feel like your performance isn't good enough with that yet, or if you've really knocked a subject out of the park, you can ignore it. The nice thing too is you can highlight material for the boards in general, and then you can select the material that's perfect for your test at the moment too.
Okay.
You can make these study sets that have, everything related to the boards, but then it will focus on your cardiology block, for instance, and you'll get a predominance of cardiology questions. It's something that the listeners really had to go check out. They kind of rate you by standard deviations of where they feel like your confidence is with questions.
Yeah.
So you can see your performance shift up as you do better with those questions. And, they kind of have like a forgetfulness curve set up within the app, which is really nice material when it comes to trying to figure out where your weaknesses are and what you're interested in focusing on, especially for the boards.
Yeah. You can, if you have other questions, I guess, about the platform, you can go to that link we mentioned, firecracker.me/purchase/ITB to take advantage of the holiday sale. And I believe you can get a 1-week free trial via that link too, right? Yeah.
That sounds right.
And if you have questions for them, you can send an email to chat@firecracker.me. Tell them you heard about the platform from the ITB podcast. On that note, I guess the update that I have for everyone is that, as you may have known, I was in the military throughout the entirety of my medical school through just now 1 month ago. I was discharged from the service, and having been stationed in St. Louis, now moved up to Cleveland, where 3 of my kids live. My wife, Elizabeth, who you've heard on the podcast, lives in Cincinnati, about 4 hours away, with our baby. But I'm free from the military and have decided to spend the next about 6 months at least doing very minimal clinical work to work rather on medical education and inside the boards. I have been trying to find a place, and initially was trying to find, an actual clinical job, fuller time job, and had not all that much notice to get out of the military and move. And in fact, most of my stuff is still in St. Louis. I have to still move that. I just found but needless to say, our production schedule is a little bit behind on the Audio Q Bank, but now that I have more time and freedom after the first of the year, we're going to be resuming a more active podcast production schedule and increasing our content production with respect to the Audio Q Bank. So if you are interested in learning while you're on the go, you can go to insidetheboards.com/QBank and learn about what we're doing to help you study while you drive or exercise or doing whatever you do. We got a kind of like a third-year clinical clerkships version of the QBank that's backed by online med-ed, and our step 1 first and second year version of the Audio QBank is currently made up of osmosis questions because they are in the Creative Commons, but we may end up actually expanding that to work more formally with other companies who want to contribute. So stay tuned for that. And I guess without further ado, let's talk nephrology. All right. So nephrology, first one. A 32-year-old man participates in the Chicago Marathon on an extremely hot day. He drinks a large volume of water throughout the race, and during the last few miles begins to feel increasingly lightheaded and confused. As he crosses the finish line, he collapses and is taken to the hospital for evaluation. There, his vital signs are the following: temperature of 102.9 Fahrenheit, a heart rate of 114 beats per minute, blood pressure of 88/54, and a respiratory rate of 22. He's awake but lethargic, and he has no focal neurologic deficits. On laboratory testing, his serum sodium is found to be 112 milliequivalents per liter. He is admitted and treated with 3% hypertonic saline to correct the hyponatremia. Although he initially makes significant improvement in his overall mental status on hospital day 4, he is found by his nurse once again to be confused, unable to answer basic questions or follow simple commands. Over the course of the day, he becomes increasingly more lethargic and ultimately lapses into a coma. Which of the following is the most likely diagnosis? A. Myocardial infarction. B. alcoholic cerebellar degeneration, C, intracranial hemorrhage, or D, osmotic demyelination syndrome. So what's the answer here, Stuart?
So the question is talking about a dehydrated patient who comes in, he gets a hypertonic saline solution administered to him, and then a couple of days later lapses into a coma without any other information really to back up why he's gone into this coma.
Yeah.
Because of that, you really have to focus in on the fact that he was given this fluid, and I would pick that he had osmotic demyelination syndrome because of just the patient presentation.
That is correct. Answer D, osmotic demyelination syndrome, which used to, back in the day when I was in med school, more commonly referred to as central pontine myelinolysis. I guess what I will say, as you go through this vignette, and I like how you broke that down. You're like, well, what are they really asking? What's the diagnosis for this dude who was dehydrated, got hypertonic saline, now coma? Right? Those are the truly essential elements of this vignette. And probably the particular answer choices that we are given here make this question on the easier end, just because myocardial infarction and coma don't seem to go together, as well as him not having elements in the history that would indicate, say, a likely intracranial hemorrhage. We have no, information about his alcohol use or other kind of findings related to chronic alcohol use. So osmotic demyelination stands out. But how does this happen? So I guess there are two things to keep in mind. You can either rapidly correct a hyponatremia, so his sodium was 112, and this causes a demyelinating syndrome, where symptoms are often delayed 2 to 6 days after correction, and they can include various neurologic kind of findings like dysarthria, locked-in syndrome, and then kind of non-specific like lethargy or coma. The condition itself can be fatal to this osmotic demyelination syndrome. So the recommendation is that you correct hyponatremia slowly, specifically no faster than at a rate of 0.5 milliequivalents per hour.
So, part of me sees how you could go wrong with this question if you were reading into it too much. So if you have a patient and a couple of days later, they are in a stupor and lethargic and lapse into a coma, I could see how you were thinking that, maybe they have a alcohol problem and been detoxing, and now, they've lapsed into a coma. But that situation doesn't really lend itself to the rest of the question vignette.
Yeah.
And then the other one is the intracranial hemorrhage. Obviously, if you start bleeding in your brain, you might lapse into a coma. That makes perfect sense, right?
Mm-hmm.
But again, we have a 32-year-old marathon runner, and we don't really have a good reason for why he would be bleeding into his brain all of a sudden.
Yeah.
There's just not enough there to send you down that route.
Right. There's no trauma. There's no focal neurologic deficit like, right-sided hemiplegia, So yeah, that totally makes sense. And I do think that it's important to keep in mind the mechanism of osmotic demyelination, because it can help you understand too that the kind of like opposite situation, overcorrecting or too quickly correcting somebody who's hyper natremic can lead to seizures, because the person who's hypernatremic, the brain will, kind of, the way I think about it, kind of like shrivel as water follows from the brain to the serum to bring down the sodium in an osmotic fashion. So if you do it too quickly, your brain shrivels up and you have seizures. That's a heuristic, but it helps. It can help you remember it. But if somebody's hyponatremic, right, then you will have water following that gradient from the serum to the brain, and that can lead to, kind of like cerebral edema, I think would be what I was trying to say, but I might just leave it at that.
Yeah, fair enough. And, going off of like cerebral edema or, having any ion imbalance is going to cause neurological findings in some fashion or another, just because you've got, you're might be in a hypertonic state of some sort, causing, in the case of like calcium, it's going to slow down depolarization.
Yeah.
And if you're in a hypocalcemic state, it increases depolarization. So any of these ions, when you've misbalanced them, you've changed the set point of depolarization in these in the nervous system, and you're going to cause a neurological change to precipitate from that.
Yeah. And I will trust you on that, because it sounds true.
Yeah, and it's different for each ion, and you're changing the point at which an action potential occurs by changing the cell's membrane potential. We don't really need to run down that rabbit hole, but suffice to say, when you start changing
I think I don't have to go down that rabbit hole, but actually you probably do, and much of our audience. So
yeah, no, it will be important for the test, but I can't readily bring it all up without a situation for each of them.
Yeah, well, I think you did a good summary there, but all right, you go through the next question then.
Yeah, sure. Okay. So a 55-year-old man presents to his primary care clinic for a 1-year follow-up. 1 year ago, he was newly diagnosed with a disease that was confirmed with a renal biopsy, with the image provided below. He lives alone, he drinks alcohol socially, and smokes a half a pack of cigarettes per day. His vital signs are as follows: a temperature of 98.6, a heart rate of 75 beats per minute, and a blood pressure of 148/92 millimeters of mercury, respiratory rate of 14, and a BMI of 34 kilograms per meter squared. The physical exam is remarkable for brownish, velvety hyperpigmentation on the posterior neck and axilla. So what is the most likely presentation of this patient when they were diagnosed a year ago? So this vignette gives you an image of a kidney glomerulus, and what I will describe it as is patchy hyaline proliferation within a glomerulus, and then it also is marked with protein cast in the tubules. The most likely presentation a year ago: A, proteinuria with no hematuria and normal renal function; B, hematuria, flank pain, low-grade fever 2 weeks after an upper respiratory infection; C, hemoptysis followed by hematuria. D, progressive albuminuria with decreased glomerular filtration rate.
All right. So the answer, before we go to that answer, so what does this guy have? Do you even really need this renal biopsy? He has diabetes, right?
Yes.
That's what we're talking about.
That's what we're talking about.
Okay. So he's 55, had a disease last year for which he got a renal biopsy. Whoops. That sounds terrible. He's got some negative health, maintenance habits, like he smokes. And his blood pressure is elevated and he is obese, class 1 obesity, and with a physical finding of brownish velvety hyperpigmentation of the posterior neck and axilla. So you probably don't even really need the picture to get it, or the exhibit to get the picture that this guy has diabetes. So the question is, in diabetes, how do these people present? How do these patients present as far as their kidney function, renal function goes? So progressive albuminuria with a decreased glomerular filtration rate. So that is the picture of diabetic nephropathy, right? Yep.
Right.
All right. So what are the important kind of like learning points that you need to know for your renal block or step 1?
Okay. So just getting back to this vignette, the physical exam finding of a brownish velvety hyperpigmentation, that's everyone I'm sure is aware of acanthosis nigricans, which they may describe or they may tell you, but that's a classical finding in someone that has
insulin
high
resistance.
glucose and insulin resistance. So clearly this patient has diabetic nephropathy. So as the glomeruli becomes damaged, a couple of things happen to, I guess, facilitate the changes that we're seeing here. So these what I described as a patchy proliferation is known as a Kimmelstein-Wilson nodule, or nodular sclerosis, if we're going to get away from the eponym.
Yeah.
But these are, these eosinophilic hyaline-looking circular segments within the mesangial portion of the glomerulus, right?
Yes.
So basically, as the patient becomes insulin resistant and they've got this buildup of age products,
the non-enzymatic glycosylation, basically the way I think of it is like in the small vasculature, like you get like a buildup of like sugar related products. Another kind of like heuristic that I use to think about the microvascular disease that occurs in diabetes.
Right. And what that's going to cause is this hyalinization of the arterioles, right? Mm-hmm. And despite this, this hyalinization is going to appear as like a thickening of the arteriole, and you would think that would make it, harder for fluid and protein to leak out, but it actually becomes the opposite, where it actually becomes leakier. And what you result in is a damaged glomerulus that just is dumping, large products such as the protein, right?
Mm-hmm.
So we had this patient who, clearly they're diabetic. I don't know why they got a renal biopsy, and they want you to know that, with these age products, there's hyalinization and proliferation within the glomerulus. It's causing the glomerulus to be damaged, and there's going to be leaking. So what you'll see is this progressive albuminuria. So there's protein being dumped into the urine, and a decreased GFR with the damaged glomeruli, right?
Yep. So that all makes sense to me, but why Okay, let's see. So the other options were proteinuria with no hematuria and normal renal functions. So that describes minimal
That's
change disease
minimal change disease.
or lipoid nephrosis.
That's our most common distractor here. Without reading into the question, you see this option and you're like, okay, well, they're going to have increasing protein in the urine, but maybe the renal function is intact. Okay, so I think the biggest point for minimal change disease is it's occurring in children, not a 55-year-old patient that it clearly is diabetic, right?
Yeah.
So this question will get you if you're not aware that the glomerular filtration rate is also decreasing, and you pick that normal renal function.
So I think break it down to decreased GFR and proteinuria, think diabetic nephropathy, massive proteinuria, but normal renal function, think more likely minimal change disease, which is a pediatric condition.
Right.
Okay. Hematuria, flank pain, and fever occurring 2 weeks after an upper respiratory tract infection. That's IgA nephropathy, right? The most common cause of glomerular hematuria worldwide. But with that one, you get IgA immune complexes deposited in the mesangial cells of the kidney, leading to damage of the glomeruli and nephritic range hematuria. But this patient's described renal biopsy is not consistent with IgA nephropathy. We don't see the IgA immune complex deposits in the mesangial cells. Instead, we're seeing these other things, the glomerular sclerosis, thickening of the GBM, and mesangial expansion. These Kimmel-Steele-Wilson nodules that you had described. So that leaves the other distractor, Goodpasture syndrome, which was put as hemoptysis
with hematuria.
Yeah. So if you got blood in the urine and blood in your cough, then it's Goodpastures. I think that's...
Until proven otherwise.
Yeah.
You have to figure that out or work them up very quickly to realize whether or not they need steroids, because that can progress and be really bad if you leave that alone.
Leading to... Because with Goodpastures, it's you have those IgG antibodies against the glomerular basement membrane, which damage both the glomeruli of the kidneys and the alveoli of the lungs. And so that damage can lead to rapidly progressive or crescentic glomerulonephritis. And in the pulmonary alveoli, a necrotizing hemorrhagic interstitial pneumonitis. So, yeah, none of those things sound good.
No, that would be very bad if you missed that and said that patient was just diabetic. But the Kimmel-Steele-Wilson nodules, that those little nodular sclerosis is not very similar looking when you see a slide compared to like a crescent pattern, right?
Yeah.
So, even without the renal biopsy on this, this is a diabetic patient.
Right.
And
so I would say let's leave the discussion there and plan to reconnect. Got some exciting kind of like guests coming up. Got a representative, probably a representative or two coming on the show in the upcoming month from Kaplan. We're going to do kind of a history of the kind of like board exams and an insider's kind of look into how questions are constructed and then placed onto the actual board exams. Got a treat with someone from Gomer Blog coming on to kind of like, I guess, provide some comic relief for our studying and board preparation. And then just throw it out there, the next version of the Step 1 Study Smarter series will probably kick off in March. And during that time, we'll be devoting our episodes to providing high yield content to help you learn on the go for you in the audience who are studying for Step 1, and we'll take that in June-ish. So check out the Audio Cue Bank. Check out Firecracker. Go to firecracker.me/purchase/ITB and let Firecracker know that you enjoy their content and that you enjoy their sponsorship of the ITB podcast. And let them know if you want Firecracker content to be part of the ITB Audio Cue Bank. If that's the case, send them an email to chat@firecracker.me, or you can always reach out to us at podcast@insidetheboards.com. We're here to help you study, to help you increase your confidence in approaching your exams, increase your efficiency while you study, and help you perform better on your either board exams or your whatever block or course exam you face in school. Thanks, Stuart, for coming on. And over the next couple months, hopefully we can continue to make this podcast a valuable resource for students and make ITB a better kind of resource for students who are trying to learn on the go.
Oh, yeah. And if anyone out there is looking to get an edge on studying and is interested in podcasting and things like that, please reach out to us and let us know what you're interested in doing, and maybe we can help you out and build some sort of relationship with you guys.
Yeah, totally. Like I said, I'd like ITB to be a kind of student-driven, more of a movement than a platform or resource. So if you have talents or you want to get involved with the Audio Cue Bank or the podcast, or you can suggest guests, you yourself want to be a guest and have something to offer, just let us know.
Awesome.
All right. Talk to you later.
And thanks to Sam and Alex from Magic Man for letting us use the track Out of Mind off their 2014 album Before the Waves, which GQ described as 12 tracks of alt joy. To hear more, check them out at magicmanmusic.com or follow them on facebook.com/magicmanmusic. As always, thanks for listening and sharing Inside the Boards with your friends.
Inside the Boards is not affiliated with the United States Medical Licensing Examination, Comprehensive Osteopathic Medical Licensing Examination, National Board of Medical Examiners, National Board of Osteopathic Medical Examiners, or any other licensing or examination body. All exam names or other trademarks are the property of the respective trademark owners. Content discussed during this program is the property of Inside the Boards or the attributed owner and may not be reproduced without permission from the appropriate entity. Inside the Boards fully adheres to the respective policies on irregular behavior outlined by the aforementioned credentialing bodies. All content discussed is for educational purposes and should not be construed as medical advice.